We looked at the clinical significance of seeing PIK3CA or ESR1 mutations in patients on the MONARCH 2 study. And the goals of the analysis were really to look at the frequency of PIK3CA and ESR1 mutations, to look at the concordance between PIK3CA and ESR1 mutations in circulating tumor DNA and within FFPE tissue. And I think importantly to also look to see how these mutations, when detected by circulating tumor DNA, correlated with treatment benefit. And so what we found was that in those patients who had circulating tumor DNA assessed for PIK3CA mutations, about 40% of patients had PI3 kinase mutations found. When looking at the FFPE tumor tissue, we found a very similar rate. There was a concordance in the high 60% range between circulating tumor DNA and FFPE tissue. And we know that rates of PIK3CA mutations are usually very consistent between breast primary tumors and metastatic sites. However, when you look at ESR1 mutations, there were about 60% of patients who had ESR1 mutations when looking at circulating tumor DNA, but only a little over 4% when looking at the breast FFPE tissue. And I think the reason for this is that the tissue source for the FFPE was really about 80% breast primary tissue. And we know that rates of ESR1 mutation increase in the metastatic setting, particularly in patients who have previously had aromatase inhibitors. So I think here the advantage of the circulating tumor DNA when compared to FFPE tissue is it was just prior to starting on trial and really more reflective of the tumor mutational status than the FFPE tumor tissue was.